do in the future, which might be a nice thing for our world. Please, if you are able to use a video camera, your video, that would be great. If you're in a position where you can't, that is also totally understandable. Please stay on mute when you're not speaking, but please unmute when you are speaking. As the moderator, I'll do my best to both do chat and voice with people. We have kind of a medium-sized group, it looks like. And then mute again after you're done speaking. This presentation is being recorded, and we hope that that's okay with everybody. If you want a copy of the recording, please feel free to be in touch with Edward at the email below. As I mentioned, this is one of two this week, but one of many occasions that Edward has brought us together. And it really is based on 3 points. One, that we need to improve the provision of spiritual care and the relationship of training, and you can see a couple references to that. Number 2, some of the benefits of spiritual care training, and you can see a couple references to that. And finally, I think for all of us, some of our own clinical, anecdotal, and other experiences about the importance of spirituality for our patients and their families. So both data as well as important stories that all of us are a part of. We have 3 panelists. I'm going to say a little bit more about them in a moment. And we will go until a few minutes before 1 o'clock Central Time, and then we will be done. So thank you guys again for being here. I am not going to read Betty's credits. I will only say 2 things. That Betty is the founder and principal of the ELNEC project, the End of Life Nursing Education Consortium, which is the country's or the world's, and I'll leave that to Betty, leading education project with nurses around end of life and palliative care. The second thing I will say, and I will repeat this about Christina and Edward because it's true of all 3 of them, is that Betty is a friend and a teacher of mine, and I'm grateful for that. So again, you can see details about who Betty Farrell is, and thank you, Betty, for being here. Christina Puchalski also has an illustrious career, and you can see examples of her career there. I will say one thing as well about Christina, and then a second. The one thing I will say is that Christina created the FICA tool, which is used broadly, widely, and deeply throughout palliative care, and we are grateful for that, Christina. Christina is also a friend and a teacher of mine. Both Betty and Christina are long distance friends and teachers of mine. And my last teacher is Edward. And Edward is a friend and a teacher and a dedicated colleague of mine. And I'm grateful for Edward's presence on this webinar and in my clinical and other parts of my life. I will say one thing about Edward as well. Edward is a Sojourn Scholar, which is a very prestigious award from the Cambia Foundation in Palliative Care. Edward is either the 2nd or the 3rd, depending on the order that you count things in, chaplain to receive this award. And he will do amazing things with this support. So here's our plan. We have 5 questions, which Edward has actually developed for all of us. And I'm going to ask each of these questions to all 3 of our panelists and have them answer in turn, and then we'll have some conversation together, and then we'll have another question, and then we'll have conversation. Depending on how good I am at timekeeping, we'll get through all 5, but we may not. There are 5 very rich questions, and it'll be a great conversation. So let's start, and I'm going to start with you, Edward, just because you're at the top of my screen here. What led you to begin your work in spiritual care training with non-chaplain clinicians?
Thank you, Josh, and thank you for being part of this conversation with Betty and Christina. To the point, it became from a moment someone asked me a question, and that someone was you as a fellowship director of Palliative Care Fellowship Director. And you asked me this one question, and I'm not sure if you recall, this was about a little over 6 years ago. It's like, so spiritual care matters within palliative medicine. how do we train our fellows to do better, right? But I would say that it was a question, but also how you framed it and how I took it was an opportunity. It was an invitation, right? An invitation to think a little bit more broadly about this. And I will be honest, at that moment, I said, I don't know. I need some time. I need some time to think about this, right? But thank you for the question. But I think that offered an opportunity for me to, one, dwell with that question, because it wasn't just a question or an invitation. It was a really deep invitation to be part and to contribute in a different way to the palliative care service, and especially in a training program. And so for me, it began having an ally, right? An ally that was offering an opportunity, a meaningful opportunity to imagine something that can be created here in the Palliative Care Fellowship, right? To address with this particular population called the Palliative Care Fellows that we have every single year, right? And so for me, that was really the birth of many great opportunities within spiritual care training. And I want to say this because I also want to say that I am not a CPE educator, right? And so that was an invitation for me to think about the educational contribution and training that palliative care chaplains lean into, right? We're not here. What I'm trying to highlight and distinguish here is I was being invited to be an educator and a trainer for a non-CPE type of adventure here, a program. And I had to be honest, it made me pause, and I had to put some thought about that, of how would this look like for palliative care fellows, right? But I'll leave it there. There's more to say about that.
Great. Thank you, Edward, for getting us started. Christina, can I ask you the same question about how you began your work in this field? You're on mute, Christina.
Always forget to do that. I developed an elective course in spirituality and health back in the 90s when I was a medical student. So just thinking back to then, what inspired me are personal experiences I had. The death of a loved one, which was not the Breaking Bad news part, and all of that around that was not so fantastic. And then when I was a medical student, to hear that, I got through that by being in a woman's support group that included a heavy focus on spirituality. And then in medical school at the same time, I was in we were learning about psychiatry and grief. And the psychiatrist said, well, if a person is grieving more than 3 months, that's pathologic and they need medication. And I just thought, no, wait a minute, he's really missing the big piece about bereavement. And the many experiences I've had with others where they felt that they weren't listened to in their, what I now realize is spiritual distress, did not realize that at the time. So that really inspired me to try to develop a course, and we did an elective, and then eventually that became integrated into our whole curriculum and continues to be so, and we continue to develop that at GW. So that I think was the main reason. And then just, enforcing that was, again, as a medical student, being with patients who suffered deeply and their stories were often not heard. And we were encouraged not to go into those areas other than sort of the biomedical, the physical. And I thought that was not really consistent with whole person care, nor just with respectful and care. So thought this is something we as doctors should be able to do, as nurses, et cetera. We should be able to ask these questions and not just leave it to perhaps the clergy person or the chaplain will address it, although back then we didn't have many chaplains at all. But really that we also need to be present, because those stories of distress and suffering, as well as joy and other parts of spiritual health are so critical. So.
Thank you, Christina. And I probably should have said, as I was introducing you and Betty, that both of you are longtime colleagues and friends and have worked together for a while, which leads me to ask you the same question, Betty. What led you to begin your work in this area?
Thanks. Well, it's a joy to be here with all of you, but particularly my three friends, and I was just saying what a great way to end this week and go into the Memorial Day weekend to be together like this. I have been a nurse for 46 years this year, and began and have continued my career in oncology. And so way back from, honestly, my student days, before there was a field of palliative care, before the word palliative care even existed in our vocabulary, my personal interest started in pain management. And as a bedside nurse, I remember sort of that aha moment where I was constantly answering the call bells of patients saying, my pain is a 10, I'm in terrible pain. And yet at the bedside, I was thinking, this is not physical pain, or it's not solely physical pain, or this is not a pain that morphine is going to solve. And so I think my first realization of the need for spiritual care came out of my work in pain management. And then the recognition that I and my colleagues, did not know how to, we may have known the right dose of morphine, but we definitely didn't know how to manage suffering or anything really about spiritual care. Then about 23 years ago, so in the year 2000, we started the LNEC project, the End of Life Nursing Education Consortium, which was when the field of palliative care was really taking off. And also in the early days, Josh was very involved with EPIC training for physicians, and I was starting the LNEC project for nursing. So we began to understand if we were going to move the field forward, it had to be about education. So in LNEC, there's a little phrase we use, which is nurses can't practice what they don't know. If we all say, oh, we want nurses to provide good spiritual care, we want nurses to call on their chaplain colleagues, that will never happen. Changes in practice will never happen without education. And so we have, we're really committed. And so from the first day of our very first course 23 years ago, spiritual care has always been one of the modules of what we teach every nurse, every course, which in January, we will have our 300th national or international training course with over about 1.5 million people trained. And every one of those courses has included spiritual care. So I think that, I cannot imagine how we could ever teach palliative care without including spiritual care. And it's really at the center of what palliative care training should be about.
Thank you, Betty. As you were talking, I was scribbling down, nurses can't provide what they don't know. And I, of course, replaced it with physicians. I replaced it with social workers. I replaced it with chaplains, with any of us, of course. So I think that's such an important insight. And, just in the sort of interest of summary, bumping into a colleague in the hall and asking a question, an early personal experience that Christina, you mentioned, and a number of early clinical experiences that both Christina, you and Betty mentioned. So those are kind of ingredients in how this was birthed, if you will, for each of you. I'm going to go to the next question because it kind of pairs well, and then open it up to our audience. What does good spiritual care for non-chaplain clinicians look like? How do you think about this? What do you take into account? What do you do to create good spiritual care training for non-chaplain clinicians? Edward, you went first last time, so you will not go first this time. I'll start with Christina. And if you wouldn't mind just checking, I think you may be off mute. Great, thank you. Go ahead, Christina.
So just building from the first question, just give a little summary of what we've done, and that will help me address what does good spiritual care look like. So from the elective, we learned a lot, and I had some wonderful colleagues on the faculty who, Dr. Jim Blatt, for example, who really supported this notion of spiritual care, and we framed it within whole person care. And so as Betty was talking about some of the initiatives, that whole person care, I think, was really important. I was also working with Dr. Joanne Lynn and Joan Tino, so certainly this started within palliative care. But our training is not just within palliative care, it goes across all of care at GW. And so in developing these curricula, there have been a couple of really important points. One is the recognition that it's not just about doctors, but it's others on the team. And so part of the development of the curriculum was looking at places where it can be interprofessional. And this was fairly early on at GW. And then I met Betty Farrell and learned about her LNEC program and thought this would be something so important that we could do in interprofessional spiritual care. And so further down the line, we did develop the ISPEC program, which is modeled on Betty's LNEC program. And that's currently the program that we have. So we've gone from an elective to required to now utilizing pieces of the ISPEC program in the curriculum. So my comments on, what does good spiritual care training look like? Well, first, we have to take into account the audience that we're teaching. So there's always been a challenge of time and trying to fit it within the curriculum in a way that does not take away from other curriculum, does not overburden. So I think in our own experience, integrating it into pieces in medical school, it's been integrated at different levels, everything's been integrated. And now we're really in a whole person way of looking at things. So integrating it into different pieces. So for example, Breaking Bad News or palliative care courses or geriatrics. But what we start with medical students is on day one, they learn about a patient called Oliver Mann, and there's different colors of Oliver Mann. And he has colon cancer, but different spiritual, different emotional, et cetera. And the students learn right from day one that spiritual health is part of whole person care. So that, I think that's the one good training, is always framing it in something that your institution already has. So it's more likely to be integrated and accepted. I think that's important. The next piece of that is looking at who your partners might be within the university. So even though we started this many, many years ago, it's just now that we've gotten a huge amount of traction. And I have to credit our new dean, Dr. Barbara Bass, who's really supportive of this notion of spiritual health, but finding partners to be able to teach in this course. So that's part of the training, is that we're not doing it alone, but we have partners, and we've engaged other people from other disciplines into how they understand this. And this could be a whole lecture, so I'm not going to go into that, but that can be challenging because you have to overcome barriers of religion versus spirituality versus culture versus time in the curriculum versus what's more important. So I would say the main pieces are integrated into the curriculum. This includes fellows and residents as well. Not requiring huge amounts of time, but being able to get across the essential pieces in something that is, again, related to other parts of the curriculum, but is manageable. I think one of the things we've learned over the years is the importance of personal and professional development of clinicians, of physicians in particular. So we developed a program called GWISH Templeton Reflection Rounds, which was piloted in 18 programs, and we have continued that in our school and now have revamped it. And so looking at how do we teach that? We developed all of our programs, starting with reflection rounds with chaplain clinician partners. So Chaplain Rick Bauer is on the call right now. He works with us at GWISH, and we're currently doing reflection rounds for third-year medical students through the surgery clerkship, with the goal of integrating it across all clerkships. So starting with, where are you with this? What does spirituality mean for you? I think that's absolutely essential. And in these days, when everybody is so stressed and they're seeing attendings burn out or quit or hear the high suicide rates, it's so important that we reconnect people with their call to serve. And I'll tell you, with our third year students, we just did our reflection round group last month. It is amazing to me how they are right there with it. It's not anything we have to teach. But what happens is that gets lost. So good spiritual care training means reinforcing, offering more opportunities to connect with that call. I mentioned MD clinician for medical school, RN clinician, a chaplain, I think that's really, that modeling is key in the teaching of the students to know what generalist is versus specialist. The faculty need training too. So we in fact have our in-person ISPEC course, interprofessional spiritual care course, coming up at the end of June. 22nd and 23rd. And we now have a number of faculty that, and this is the first time in the history of my being at GW that this has happened, where the dean and others have said, invite some of the other faculty. So we have faculty coming from different areas, palliative care, surgery, et cetera, to this course to be able to enhance what they're teaching. And then I already said, start day one. We need to really have that in the medical school curriculum. So I think just in summary, start early. We use the existing ISPEC online course with faculty use that in different pieces of their curriculum. I teach an elective in palliative care with Chaplain Rick Bauer, and we use the 6 modules of the ISPEC course. And they do a module, then we meet, we talk about it. Then they go to the hospital with Chaplain Bauer and see what it's like in that environment. They see me in my clinical environment in the outpatient setting. So how do I do it? Modeling again is key. So I think I'll leave it. I'll leave it at that.
Great. Thank you, Christina. Edward, what are some ingredients of good spiritual care training from your perspective?
Thank you, Josh, and thank you, Christina. I was nodding my head and saying yes internally for everything that Christina was highlighting. I echo many of the, but without sounding redundant, the one thing I like to highlight, and it actually was prompted by a conversation I had with Christina about 6 years ago, and it was this awareness that spiritual care training has many different intersections with different clinicians. And so what I mean by that is what Christina was highlighting, that they meaning clinicians, whether social worker, medical students, physicians, etc., will intersect some type of spiritual care training or have the possibility of intersecting spiritual care training at various points of their career, right? And I think that matters, that awareness of how and where it intersects matters, because it also guides us of how we respond appropriately to where they're at in their professional development, right? And so my response of what good spiritual care training looks for a medical student would look very different, right? In year 1, year 2, year 3, year 4 of medical school, right? And it would look very different for a fellow who is doing a surgical fellowship compared to a fellow who is doing a palliative care physician fellowship, right? And so I spend for our program, we have allotted 46 hours with our palliative care physician fellows as an embedded part of their fellowship to strengthen this domain, this aspect of their clinical training, right? But I would highlight that looks very different for different fellowships. We have different guidances, right? Guidelines and competencies that we have to be aware of when we're thinking about fellowship training in palliative medicine, right? But the other component that I want to highlight is that so I'm talking about a robust spiritual care training response, right? That is an intensive experience. So for example, just using this as a sample population, the palliative care fellows, we're with them 1 year, right? And so this will look very different, but it doesn't end there. Christina was highlighting something very important, and it was this longitudinal piece for them. It doesn't start here for the fellows that we're journeying and training together for this 1 year, but it's again planting some major things here, the seeds, because there has to be a longer trajectory about their exposure with spiritual care training in the long run. And I will frame it in this sense, continuing education, right? Where they're probably not going to go through 46 hours again in their future, right? If they wish, that's excellent. But maybe moving forward for the fellows, it looks like 1 hour per year or 1 hour every month or whatever that looks like. And I think that's important to highlight, because I think when we're thinking about our attendings, for example, right, they have gone through training, whether a formal training or an informal one. They have worked with me. So that spiritual care training response is subjective in the sense that it has to meet them where they're at, right? And so there's this other component. So for me, what I'm highlighting are 2 major components of an intensive training program, but as well as a longitudinal continuing educational part, right? And so that guides many other questions that flow for us as spiritual care trainers, right? And that is what Christina was highlighting about time. I would use this term that I think many of our clinicians here present would appreciate. Dosage matters, right? And dosage in education matters. Like, so if you're asking me to train for spiritual screening and spiritual history, right? How much time, right? And so is it 1 hour? Is it 2 hours? Is it 3 hours? And so that response, that answer to that question about dosage at different trajectories of their development and their careers, that will be very different for every single person receiving that spiritual care training. And I'll end there.
Edward, thank you. I'll just extend the metaphor for a moment and just sort of pose this as a hypothetical question for all of us, which is also a medical question, which is how do we figure out the dose? Betty, do you want to talk a little bit about an ingredient or two or three in good spiritual training from your perspective and your experience?
Sure. I mean, I definitely echo everything that Christina and Edward shared. I love Christina's work specifically in the area of vocation. If we can get nurses or social workers to really reflect on why did you even enter this profession? What was your calling? What did that feel like? When people can reconnect with that calling, I think that's such a huge step. In terms of kind of some ingredients, I really echo the issue of the generalist versus specialist, that's such a strong concept in the field of palliative care now. And we really need to emphasize that if your daily work is, to be an ED doctor or a pulmonary doctor, oncologist or a nurse, working in heart failure, like how can you possibly do that job without having generalist knowledge in spiritual care? Our chaplains are our specialists, but we need all clinicians to have generalist knowledge in spiritual care. So when we build spiritual care training through LMAC, we also have a program called our ICC course, which is interprofessional communication training, where we bring together chaplains, social workers, and nurses. So as we build curricula, the few of the things I would emphasize, one, I always refer to it as the broad brush spirituality, that yes, we'll talk about religion, we'll talk about, different religious traditions, but spiritual care training always needs to be the broad brush, where we talk about meaning and purpose, and we talk about suffering, and we talk about, other aspects of spirituality, beyond religiosity. I think a key ingredient has to be self-reflection. We, in our LNIC training, I've shared this many times, but because communication is another big part of our training, we have a checklist where we have participants rate. So we give them, here are all the things you might need to talk with patients or families about, all the areas of communication. So talking to someone who just got bad news, talking to someone whose disease just recurred, talking to somebody about completing an events directive, talking to someone about sexuality, talking about spirituality, talking about, the impact of illness on their family. So we have this long list, and we ask people to rate what is the least difficult communication you have, what is the most difficult. In every survey we've done, this now goes 15, 20 years, every single survey, talking about spirituality is rated as the most difficult thing for non-chaplain clinicians. Absolutely the most difficult, every survey. And as we've done this over the years, the numbers have gotten worse. They're even more afraid. And so again, what we're seeing now is that as our populations become more diverse, clinicians are even more fearful. Clinicians, nurses will say, I'm Catholic, and if I walk into the room of a Catholic patient, of course, I'm comfortable. But if it's anyone else, I'm not comfortable. And so, we need to really, again, the need for education and the need for self-reflection. One of the other common comments I hear from nurses is, I often lead this small group after we've had this spiritual care lecture. And in the small group session, nurses will say, I don't even know about my own spirituality. How can I talk to a patient about spirituality? And, you know, there, yes, that's true. Right? That's the point. And so the things, you know, Edward and Christina shared about self-reflection are so important, and that's a big ingredient. And then finally, you know, I would say presence and listening, that if we can get clinicians to be more comfortable with being present, with being silent, with listening, then they will hear the patient's stories about spirituality. So those are all really important ingredients.
Thank you, Betty. Christina, you came off mute, so did you want to add something?
I do.
Please.
So a lot, you know, just this conversation is so wonderful. You know, when we're talking about physicians in particular, and Betty, I'm curious if you think it's the same with nurses. My experience, not. I think nurses are a little bit more open, but when physicians need to know what is our role, we're taught to diagnose and assess. So one of the early things I recognized was to talk about spirituality as distress, and that this is actually all of our obligations. It's not, you know, push the button and refer to the chaplain. I think something else is going on. We actually, and we need to do this better in our training too, is we need to use the regular assessment kind of focus that we use for anything else. Okay, it sounds like this may be spiritual distress, or is it depression, or is it worsening physical pain, you know, using that discernment process. So yes, I think clinicians need to go more than just ask the question. We need to really get into, is this distress, or is it a really strong spiritual health? They have great support systems. They can continue that. You know, there's, yeah, I think it's really critical to look at it in that way, because we need a reason, right? And that's the struggle sometimes that I've had. And it was until we were able to frame with Betty the palliative care in 2009, and to say, look, actually patients do get spiritual distress. It can look like these things. It's not just religious. It's could be despair, hopelessness. And we in fact have an obligation to do that. And then if we're lucky to have an expert, a chaplain, a spiritual care specialist, we need to work in partnership. But it doesn't end there, because we continue to follow up, depending on our field, but continue to follow up on that. Surgeons do that. We have an anesthesiologist that's now working with us in pre-op. He does that, you know, or in the ICU. So it's again, this is not an option, right? It's just like when Betty's research and others, and when I worked for Joanna Lynn Jontino, you know, assessing pain was important. The support study, you know, developed that. Well, spiritual pain is equally as important. And I just want to emphasize that that's what good would look like too.
No, thank you, Christina. So I want to open it up to our audience. And again, if you're able to come on video, that's great. If you're not able to, also understand that. We have a small enough group that I think we can actually share by voice, but if you are able to use the raise hand function, that'll help me be a little bit more organized. And just any reflections or reactions, we'll talk for a few minutes, about 3 or 4 minutes, and then we'll go on to a couple more overall questions. I'm going to stop sharing screen so I can do better with seeing everybody.
As we're waiting, and I just want to invite everyone to engage in our conversation here. I did want to join Betty and Christina as I was listening to their reflections. And one of the questions that I encounter, and this was raised by Christina explicitly, is the rationale. Why should I be doing this, right? Why should I be doing this? And why should I train for this? And I mean, that is a question I frequently have to address many different times, even though they're not explicitly asking. That's dwelling with them being whichever clinician I'm working with. And I would want to say this, that it's a very important question. It's a valid question. I don't get defensive about the question, right? I don't have a strong reaction. It's a very important question. I think that I would ask myself if someone was inviting me to do something else to train on, right? And so I say that because it doesn't come from a place of malice for many of them. They're asking a great question, and that to be prepared, right, to respond to that. They want some guidance, some rationale why this is important. And Christina was highlighting that for her, it was this hard to address spiritual distress, right? And it can be a combination of other things. The other piece is I'm very much a student of culture and history. And so I also, one of the things that I love to highlight was how spirituality manifests itself in the way they communicate, in the way they make decisions, how they think of their reality, themselves, their humanity, including how they're making medical decisions, right? And so it does matter for them, right? So I'll be very explicit. One of those ways is when a patient or a family member or a decision maker says, you know what, we're hoping for a miracle, right? Mm-hmm. And so there's deeper things that are at play here, right? And so I think, again, it goes back to what Christina was highlighting about, right? The rationale question, the why question. Why should I do this? Why should I train for this, right?
Edward, thank you for that. Appreciate it. Any other reactions or reflections that anyone wants to share? Please feel free to use the raise hand function, or also feel free to put it in the chat as well, whatever is easiest. Rick, you've put in, I hope it's okay to call you by your first name. It's just easier as I'm reading. And by the way, I'm taking that liberty with Edward and Christina and Betty, so I hope that's okay. Rick wrote in the chat, I believe yesterday and today we've been talking about nurses, palliative care, physicians, fellows, and residents, and today even more broadly, surgery, cardiology, etc. But all caps, what about and how do we engage hospital management, DON, which I think is Director of Nursing, administrators, and as to why this training is important. So do any of the three of you have thoughts about, and perhaps anyone else in the audience, but I'll start with you three, how we engage some of our administrative colleagues in this endeavor?
So Rick, I can start actually, because it just happened this morning. So we had our palliative care division meeting, and in our clinical site, we have a new position that came in high level. He's an attorney, but I don't exactly know, but he's coming to sort of fix things up and in our clinical environment have things move more slowly. And in the discussion, he was very present to each of the faculty members' comments. And so I think, I took advantage of the fact that we're all stressed and burned out. And he brought that up, that he walks around the clinical settings and people are in their own silos and they're, everyone's stressed and, all of the things that those of you that are clinicians with any new Epic or whatever version you're working with, it's challenging these days in the wake of COVID. And so I did mention this work and he's very, very interested. So I think it starts with showing up. Showing up at meetings if you're able to, and then just listening to the thing. I didn't have an agenda to say anything, but once I started hearing demoralized clinicians and nurses and staff, how do we deal with that? To just have an opening to say, well, there is this program, or we can talk further about. And I think that's one way that I would think about doing that. And I'm going to look to my colleagues because I know that they also have had to work at that level.
Betty or Edward, do you have other thoughts?
Yeah,
No.
Go
ahead.
Please go ahead, Edward. Sorry.
Yes, I would say this, there's many different paths to response. And I'll just share one as an example that we have encountered here of, and I'll use this term and I can elaborate a little, poking the bear, right? Poking the system, and poking it very assertively, but also dancing with the system. We want to be colleagues as well, right? And one of the ways that we did it was, one, we can go directly to the higher staffer, the administrator, etc. And I've learned that I have to be very, very patient on how the big ship runs and functions and makes decisions and steers, right? And so that awareness of knowing how the big ship steers or moves, it helped me more to be a little bit patient and not have, I still have expectations, right? But it's helpful to be aware of that. I should not expect a massive change of policy, of practices in a month or two, right? So one, it's helpful for me, right? And my energy and my frustrations, right? I would say the other opportunities that I have found is I'm very grassroots. And what I mean by that is if I can collaborate with my clinical colleagues in the unit, with my palliative care team, with other clinicians, as Betty and Christina were highlighting, that's powerful, right? And we begin with the nursing population. We'll begin with the medical school population of small sample. Then we can create bigger momentum, and then we can make greater movements and build a case for a bigger contribution, for example, residency groups, etc. Right? And so I found that to be helpful for my setting, right? And I'll end there.
Great, thanks, Edward. Anything you'd add, Betty?
Yeah, I could give good advice on how not to do it. Because, Edward's comment, it's the notion of, carrots and sticks. And I can tell you that early in my career, when I was focused on pain management, I'm sure I spent a few years going around and hitting everybody in the head with a brick and saying, you are doing a terrible job. We are horrible people. Our hospital does a terrible job in pain management. You are all ignorant. You don't know anything. And then I, stood in shock why people were not lined up, right, to come to education. And so it took me a long time to catch on. But I think whether you're trying to educate a hospital administrator or a department manager or a nurse, a physician, the message always has to be an invitation, a positive invitation. And so, the message I try to say is we are a leading cancer hospital. We are one of the best places in the country, or, you are such a compassionate nurse. And I know you care deeply about the patients you serve. And here's, one more way. I know that you will want to do this. And it is, of course, been astounding to me how people are so much more receptive to, to being honored and respected and to have an invitation to build on good work rather than, like we never want to advertise an educational program as come to this because you're very ignorant and doing a bad job, right? So I still have to remind myself of those lessons, but it definitely makes a difference.
Thank you, Betty. I love those expressions. So we're going to move on. There are 2 more questions and 13 more minutes. I'm going to be pretty intentional with how I ask these next 2 questions. The first one is going to be about challenges, and the last one, I won't reveal it to the audience. I want to spend a little bit more time on, actually. So I'm going to reshare my screen just so people can have it in front of them. So I'd like to focus each of you. So each of you has 1 minute now. That's your challenge, by the way, to talk about a challenge or 2 that you've experienced. Edward went first once. Gosh, did Christina go first second? Betty, you're first.
In terms of nursing, I'll just speak to nurses. Nurses are so incredibly busy. They are, the clinical load, they are so frantically busy. And so when we say we want you to learn about spiritual care, that's the biggest challenge. And the other thing I would say is, nurses are trained from their first day in nursing school to fix things, right? You're in pain, I'll get medicine. You're constipated, we'll take care of that. You have urinary incontinence, we'll fix it. And, people often say physicians are sort of trained in a fix-it mode. Nurses really want to fix everything. And so I think the challenge is getting nurses to really rethink what is their real role, and that to listen, to be present. And also, something I've shared recently with nurses is in all of my career decades, we have collected hundreds, thousands of stories from patients. And I say to nurses, in all of these stories from patients, when I say, tell me something that really impacted your care, what helped you get through that first day when you learned you had cancer? Never in my career has the patient said, oh, there was this time when a nurse pulled up a chair and sat and talked with me for an hour. That has never happened. But what patients say all the time, they tell me stories of what happened in 1 minute. The doctor said I had cancer, And the nurse who was standing there, before she left the room, she just walked over and touched my hand and stood there silently for maybe 10 seconds. And that changed everything. So I think if we can help nurses understand it is not about fixing and that it is not about a lack of time.
Great. Thank you, Betty. Christina, 1 or 2 challenges.
The same thing with physicians about fixing, and we probably even worse. I won't reiterate that because that's the same thing.
I think you guys are going to have a contest about who's worse, the doctor or the nurse.
Well, I don't know worse, but you're getting pressured under time. So I think training. Okay, so one of the things in training is, being able to do it in a way, and this, it's time. All of the issues that we find has to do with time off. Can I take time off to do this? So with our ISPED course, we've actually changed it over the couple of years. Instead of saying, go back and train 20 people, we leave it up to the people that are coming. Who can they train? And then we've changed the content a little bit in the curriculum. We have a lot of resources people can use and et cetera, but you'll hear us saying, if you have 10 minutes to teach, this is what you can do. If you have 30 minutes, and that is to me the number one thing, even as people are calling about the ISPEC course coming up, how much time is it going to take? So everybody, I don't think it's that they don't think it's important. I think it's an issue of time. And in terms of common questions, it's less so now, but still, is this about religion? What is this about? Is it appropriate? Is it not appropriate? Much less in my environment now, but I still keep hearing that. And to that end, our global definition that was built on the 2009 meeting that we did with Betty is a broad definition that I use, even in how I talk to people about it. So languaging that this is really whole person care. This is about the spiritual domain. It's not necessarily about religion. And, it's important that we connect and relate to. And then the compassionate presence piece, to use those words often is hard, but everybody wants that. And in our reflection rounds, that's what the students learn. They appreciate being listened to and not interrupted. And in so doing, they learn to also not interrupt their patients. And so even our faculty that have learned from the reflection rounds have been able to change their practice. So professional development, I think, is finding time for that in the midst of, artificial intelligence taking over, blah, blah, blah. So, really, those are my points.
Great, Christina, thank you. So temporal challenges, linguistic challenges, and professional development challenges. Edward, is there a challenge that you would add?
Yes, I'll take this to a different direction, and the challenge is me, right? And what I mean by that was growing an awareness that as I was leaning into this work of spiritual care training had a lot of implications for me as a professional, right? As an educator, and as to be trained as well to be an educator, right? And so this becomes it can become a struggle, a challenge, because this implies about certain competencies that as a palliative care chaplains, you don't get trained to do this, right? To be an educator, to be a trainer, right? And many, many things you develop along experience and etc. And so there was this challenge about this is going to other realms of professional developments, and I need to be aware of that. And that has implications for me, right? I want to lean into this, right? I want to do this work. And I say this out loud because I don't think I'm the only one, in the sense of chaplains that are in their setting, right? Our background probably is not in curriculum development and education and trainer, and we don't have those experiences to develop in such ways. And so I think that had to be, I had to pause with that. I had to dwell with that, and I had to respond to that for myself if I was thinking seriously about developing myself as a professional to offer this type of training. So I would say that.
Thank you, Edward, and thanks to all three of you. This is our last question. And again, I'd like you to be relatively focused, if that's okay. I appreciate that. And this is from you, Edward. All credit for all these questions to Edward. And it's about the beauty and the meaning of spiritual care training. So I'd like each of you to reflect on that for about a minute, and I'd like you to focus not on the beauty of spirituality or even clinical examples of spirituality, but of training specifically, because that's, I think, the spirit in which, Edward, you're asking the question. That's connected with, obviously, clinical examples and experience of spirituality, but focus on what you see as the beauty and the meaning of spiritual care training. We will go to, actually, we'll go to Edward, because you started first on the first question, so you can start first on the last question.
Okay. I think for me, the one I do want to highlight is the very genuine space of dialogue with many clinicians, right? To pause and to reflect about the way we look at humanity, the human experience, everything that is involved in when we enter into a patient room, and to have this opportunity to, whether you're a nurse, a chaplain, a physician, a social worker, that we have this space of mutual respect and values and expertise for each other, and that we can share that meaningful conversation about what we see when we enter a room, and what we hear and listen of a patient and their values and their beauty. That is beautiful for me. When we're able to share space like that and communicate in such ways, I think not only benefits me as an educator, as a clinician, it benefits the team, but I also think it benefits the human beings that we're caring for and their loved ones. So I will stop there.
Great. Thank you, Edward. Betty, how would you think about that question?
I think if we provide good spiritual care education, and then the people that we train go back into the work setting, it will change every aspect of their care. It will change the way they do patient teaching. It will change the way they manage pain. It will change everything that they do. And so, I just see it as the core. It's not an option. It's not the last thing, we should be concerned about. It's the core. So teaching spiritual care, is the way that we care for our staff. We keep them, in this caring profession, but it will impact every aspect of their care.
Thank you, Betty. Christina, how would you reflect on this question?
It's the aha moments that I see with the learners. Not just, okay, I get it, we'll do this, but really the sort of, it's really something just integrated inside of themselves, that I get this, I get the connection. It brings me back to my call and purpose. Those moments or in reflection rounds when the students are sharing so immensely without even using the word spiritual, they are sharing about that inner life, about that creating that sacred space, using words like just, something changed in the room. I'm entering a sacred space, or I'm entering a space to be present, to listen to that story, or, the enthusiasm they have, or the emails that I've gotten from, people even like 20 years ago, they say, these are the stories, or some, other colleagues who share stories about their encounters with the patients after they've been through a training, I think is key, and it is to build to what my two colleagues said. There's this, I believe that addressing spiritual care is the essence. You have to start there before you do anything else. And then, not that we're four pieces, but addressing whatever physical issues, emotional issues, et cetera. But it stems from that. It stems from what many of our learners say, I am walking into a holy space, and the preparation to walk into that sacred space, what they've learned from that. And then their stories, or when they witness that in the room with me, or I witness that with them. That's really the beauty with the training. It's the transformation and the hope for the future.
Thank you, Christina. And thank you, Betty and Edward, for your answers as well. I'm sensitive to the hour, but we have about a minute or two, and I do want to see if there are any. I will stop sharing. I want to see if there are any comments, reflections from our participants. Anything that anyone else wanted to add or share? I will respect the silence, but not too much by talking now, because I want to make sure that I end where I started by thanking Betty and Christina and Edward for being so open and generous with your time and your thoughts, obviously throughout your careers, but specifically for this last hour. A special thanks to Edward, because he was really the organizing force and the leader behind this webinar, and as I said, many others. So everyone, please put your hands together virtually or in reality for Edward and Christine and Betty. Thank you guys for educating all of us today very much.
Thanks, everyone.
And
Thank you.
take good care, everybody. It's
Thank
great
you,
to see
everyone.
everyone. Bye-bye.